Good morning, everybody. And after a breakfast course, it is a course for ruptures. So what does that mean? And Priya is here all set with a wonderful array of videos, and every course coordinator is a phenomenal person in his own right. So we are going to look at videos, look at the difficulties, look at the complications, and look at every course for the management. The course of management is going to be different, and I would really request you to interact with us and ask your questions, basic, advanced, or whatever, because we need to learn from each other. This course of Priya has been an acclaimed course even at ASCRS, so let's look forward to a wonderful course today. So posterior capsulorhexis. When posterior capsular rupture has occurred, the savior is posterior capsulorhexis. If you can make that rupture into a rhexis, the job is done. The capsule, if not intact, is a capsule in which you can place an intraocular lens inside the bag. Therefore, the first step is to assess whether you can create a posterior capsulorhexis from that rupture. So let us look at this video. And this video is going to show us that is it possible to do a rhexis in case of every rupture. So this is a, can lights dim please. So if it is a very large PCR, and there is nothing that you can nearly see, or just a little bit of the structure of the posterior capsule is just seen in some parts, it is possibly not possible to complete rhexis from this. So what you need to do is to push in viscoelastic, use viscoelastic as a tool to separate the vitreous, have the fragments right up, do a phacoemulsification with low parameters, get these fragments out as much as possible without them going down to the vitreous, do a vitrectomy, do a cleaning of the cortical matter, which not necessarily be along with an irrigation. You can use a dry aspiration with viscoelastic and then place the intraocular lens in the sulcus. And you can see that the sulcus is well defined. Once the 3-piece intraocular lens is in the sulcus, you can also capture it, and the job is done. Your intention is to have a well-placed, a stable anterior chamber, and doing the right thing for the right eye with the right complication. And of course, a vitrectomy, whenever you have to do, it is always a vitrectomy assisted with triamcinolone, because what the eye cannot see, you have to have the assistance of triamcinolone. Now here is our second case, and we are doing quite well, and suddenly we feel that everything is not right, and possibly there is a posterior capsular rupture. And this rupture is a central one. It's right in the center, so something can be done. So the first thing that you need to do is the viscoelastic has to go into the bag, it has to support the rupture, and then with a microforceps, you need to come in from the side port and do off a neat capsulorhexis. Yes, how neat will be dependent upon how stable your bag is, how stable the posterior capsule is. But if you have got a very ideal situation, and this is one of the more ideal situations, then you can very safely put an intraocular lens in the bag and then go ahead, do a vitrectomy and close the case. So what do we learn from this video? We do learn that the side port entry, which does not let egress of the anterior chamber, is important, and the microforceps is a very important tool. But can you do rhexis also with the Utrata forceps? Yes, you can, and this has been a very difficult case, and you can see with the Utrata, I have been able to carve out a small capsulorhexis from the rupture, and After that, sweeping in the vitreous from the anterior chamber, you can see 5 hooks all in place. Quite a difficult surgery we had. But vitrectomy is very important, and the management of the anterior vitreous is extremely important before you put the lens inside the bag. In this case, of course, we are going to put the lens in the sulcus, and in this case, we would capture the lens with the anterior capsule. So the vitrectomy has to be as complete as possible and as well defined as possible. Let's go on to the next video, and this is again a PCR that has occurred. And here we have a large nucleus fragment, and we have the cortex as well. Now, what did I do wrong? The wrong thing that I did is I took out the phaco probe without injecting from the side port. It is very, very important that we inject from the side port, and then only we take out the phaco needle from the main incision. So again, if we are able to support the capsular bag with viscoelastic, and you can still see that I'm taking off as much as possible of the cortex by dry aspiration, placing in visco in the bag, having a well-defined bag as much as possible, and removing it and refilling with visco as many times as possible. The fragment, as you can see, is still there. I'm not going to do anything about the fragment because I think I can place this intraocular lens in the capsular bag. And that's what I've tried. So why did I not try to take out this nucleus fragment? It is because I did not want to put in the phaco probe once again. Once this single piece lens is in the bag, I will go ahead and take out this nucleus fragment, which can, even if it is bigger than this, we can take it out with the phacoemulsification as well. So another very important point that has to be ascertained is a single piece lens in case of a posterior capsular rupture should be placed only in the bag, never, never, never in the sulcus. If it has to be placed in the sulcus, you have to place a 3-piece or multi-piece lens in the sulcus. Now, what is a situation in which there is a PCC, a PCR, and this PCR is a transverse rupture? With a transverse rupture PCR, can you still put an intraocular lens in the bag? Well, let us look at this. It's a very important technique. So what I'm doing is I'm placing this single piece intraocular lens and landing it over the iris. So over the iris, I'm landing it, and we have a hammock of the posterior capsule. And what I'm doing it, not twirling it around, but just wheeling this, the leading haptic into the space between the anterior capsule and the ruptured posterior capsule. This has to be very, very well seen. It has to be done under high magnification and with a separation between the anterior capsule and the posterior capsule. If this is done well, this hammock will not be disturbed for life. It will stay on for life. And the last case that I need to show you is what we talked about is the transverse rupture. This is a longitudinal rip, which is a little different from what we had. Now, with a longitudinal rip, and both these cases are the PCC, I'll just take 2 minutes, the last video. Both these cases were PPC, the posterior polar cataract, and in these we have these ruptures which run out right into the periphery. So we have this hammock type aspects. Now, taking off the cortical matter, and I know the rip is there. So in this longitudinal rip, you will see that one part, this part, is larger and the other part is smaller. So these are aspects that you have to see. And again, we land it over the iris. And once we land the lens over the iris, then what we need to do is in the anterior chamber itself, we need to swivel out the lens and place the haptic again between the anterior capsule and the posterior capsule. Best, the more difficult question first in an examination, and that is wherever the anterior capsule and the posterior capsule is smaller. So we did the first on the left-hand side where it was smaller, on the right aspect Where there is a larger space, we place the lens, the haptic, in between the anterior capsule and the ruptured posterior capsule. Thank you very much for your patient hearing.